I think I would give some takeaways on what should be some practices one needs to keep in mind to be safe and prevent these complications. And I think because there's a lot, there's Lura also, there is IP, so I think there may be some overlap. So I think bear with me. So this is how you round it off. Safety first. So there's nothing, I can say that planning a procedure before you start it which is going to, help you prevent the complications. And if you've thought about it, and that would be the most important thing, because most of the times we are on the side that we are so fascinated with doing the procedure that we forget to talk with our team that what could go wrong, and not just going, thinking what one thing could go wrong, what if everything goes wrong. So, interventions can be performed both using a flexible and a rigid bronchoscope. Many proceduralists would be doing therapeutic procedures with a flexible bronchoscope in mild sedation or some deeper sedation with an unprotected airway. These are done. So, you need to have some things in mind once you do that. With a rigid bronchoscope, you are more safer because you've got a large access. But if you see the rigid instrument itself is, a steel instrument, and also you have a lot of manipulation going on the patient's aspect. That can also, it might seem so innocuous, but can lead to complications if you don't take care of it. The most important thing which is going to prevent the complications more than intra-procedural is also pre-procedural. So before you start the procedure, it's not rare to see that you have a patient landing on the table and now you feel that I cannot open the mouth and the relaxant has been given. So you will have a situation, patient has big incisors, some teeth are moving, and that you realize once the patient is on the table. So that should not happen. You should have that assessment before you start. And for people who are doing it under sedation, an OSA risk assessment is very important because one of the commonest complications are sedation related. An obese patient, you push a little bit of midazolam and fentanyl, and you see the patient snoring and apnea happening, and you're rushing with your ambu and mask to do that. So simple things, but you need to keep them in mind. The most important thing I have termed this as a radiophysiological assessment of degree of obstruction. Most important thing, before you start a therapeutic procedure, see the CT, see the patient. This is radiophysiological. How severe the obstruction is and how sick the patient is looking because of the obstruction. Because that is going to decide how quickly you need to act on induction of anesthesia. If your patient has severe accessory muscle use, CT shows a very narrow trachea, your preparedness has to be much more than you are doing a normal trachea and a tracheoaxial fistula stenting. So you don't have that assessment. Check the comorbidity is very important. Sometimes it's missed and you feel that antiplatelet is being given. Equipment functioning, we have a detailed talk by Dr. Girish, very important talk. I'll not go on that, but it is very commonplace that your equipment doesn't work. You want to do a cryobiopsy and the cryo machine is not working. You want to do electrocautery and a snare. You loop the snare and the snare does not work and you cut without cautery. These are real life scenarios. Very important is planning versus preparedness. There's a difference. Planning is if you go thinking these are the steps, my procedure is to work that way. But preparedness is different. Preparedness is you talk with your team, what will go wrong? If I'm doing a tumor debulking, what if the tumor bleeds profusely? What if hypoxia happens? What is my next step? These are things not for between the procedure, but these are things to be discussed with your team before the procedure. You should do that. Rigid bronchoscope, it's the optics and the scope are different. You hold them together. And what is the most expensive piece of equipment in a rigid bronchoscope assembly is your optical telescope. So don't hold it where you put a lot of pressure and you damage your expensive telescope. That's a complication. That's a financial complication, and that can be a problem. Also, the beveled edge of the scope is hard. Once you intubate, take care that you don't damage the pharyngeal structures. So these are things which has to take in mind. And also, your flexible bronchoscope is invariably used to the rigid bronchoscope, and if you don't take care, you can damage your flexible bronchoscope by excessive manipulation. That's also a big financial issue. So if you are doing procedure under sedation, the pre-procedure assessment is important, fasting, vitals. Cardiovascular risk assessment is also very important because many people would have seen unusual myocardial events happening during these procedures, especially in elderly patients where you have not done a careful CAD, coronary artery disease assessment, and you can have new onset atrial fibrillation arrhythmias happening, which is important. For thoracoscopy, the patient is positioned in a decubitus position. So cannula is sometimes placed on the opposite hand. So it's better to place the cannula on the side of the effusion on that hand, because that will give you a better access rather than a hand which is over your head. Coughing patient, there can be a lot of difficulty, so prepare that way. And very importantly, in fluoroscopy, always do your ultrasound yourself before the procedure. I cannot mention this again and again. This is commonly done. The consultant will not do the procedure themselves. The assessment is not good, and you go inside and you run into a problem. So once you have the pre-medication window, recheck consent, fitness and bleeding tendency, confirm the correct sites and do the ultrasound. Antibiotic prophylaxis is not recommended before diagnostic and therapeutic bronchoscopy routinely. But if there is a risk, patient is a risk factor for infections like asthenia, prosthetic heart valves or endocarditis, give antibiotic prophylaxis. These are things which are not taught by IP physicians, and take care of that. This is what would happen if you've not done an ultrasound yourself. There is a restricted pleural space and you give an incision and then you land up into a no entry kind of a situation. And also you may land up into a situation in which there is a restricted space, your trocar maintains, and these are real life scenarios when you can get a laceration on the lung if you've not done the ultrasound. Some points specific for thoracoscopy. Once you're doing thoracoscopy, you are wanting a pneumothorax. So if you have a pneumothorax and maintain that pneumothorax during thoracoscopy. Keep a watch on suction pressures. We don't do that. It's a habit that our assistants would, connect it to suction, full suction on. And you just put your suction off and put the thoracoscope in the pleural fluid. Massively the fluid gets suction and you can have a rapid lung expansion. So this can lead to re-expansion pulmonary edema. You can have profuse coughing of a patient once you don't watch over these suctions, and these can be a problem. We had a lot of things mentioned regarding the pleural biopsy. I'd like to mention it again. Stick to parietal pleura. Take biopsies overlying the rib. Avoid the intercostal space. Use a pinch and peel technique. Don't biopsy from the same site repeatedly, going deeper. That can lead to bleeding. And also one very important thing is, sometimes we tend to open the forceps before reaching the lesion. It's a good habit to open the forceps only once you are close to the pleura, because sometimes a lung may be moving in between and the forceps is open, you can inadvertently cause. So these are simple things, but they make a difference once you do a safe procedure. Room safety is important. Height adjustable table is preferable, because sometimes say you are an operator, you want to transfer it onto another operator who has a height difference and your table is not moving. There will be issues in doing the procedure. Check care of oxygen and suction equipment. Full equipment check. And fluoroscopy is an entirely sterile procedure. This is a problem which happens. You tend to use your bronchoscopy suite in a way. I want to do thoracoscopy. This is not the way. It's like a surgical procedure. And you always take full surgical precautions during thoracoscopy, because one very important complication of thoracoscopy is post-procedure infection, and keep a watch on lignocaine dose. I think we had a case yesterday, Dr. Tharmesh, 2 ml of lignocaine.
Just 2 ml, I swear.
2 ml of lignocaine and that. So we've gone through that. We've seen patients with unexplained seizures after a very low dose of lignocaine during diagnostic bronchoscopy. So some patient may be sensitive to the neurological effects, and these things are possible. Now coming to therapeutic procedures, the team is very important. Once you are doing complex therapeutic procedures, better to have 2 operators who can interchange the roles. So both should be comfortable in handling rigid and flexible independently, because it's a real life. Someone is doing, cannot handle that lesion, but other person can. You need to switch the roles. That is important. Train your technicians, nursing staff. Anesthesiologist consistency is also very important. One person coming again and again is better. They will have that communication with you. But if your anesthesiologist is switching every time, you are explaining, having that discussion again, it's a draining task and it can lead to a problem. Prepare for a post-procedure care. Surgeon and ENT backup is required in certain scenarios. What are those scenarios? I would think once you are dealing with a vascular endobronchial tumor debulking, like a carcinoid, it's better to inform the surgeon. Because sometimes, even in the best of the scenarios, you may be not able to get the tumor out completely. And there may be profuse bleeding, which may be very difficult to sometimes manage. You may be able to, control it temporarily, but I think the patient may require to go for surgery. Most important, CT scan. Evaluate your radiology well before the procedure. before you even move close to the patient, always go first to the CT scan. Especially in an obstruction, if you are planning a tumor debulking or a coring, if you don't have a distal patent airway, what are you going to do with coring? So always have an assessment of the length of the lesion, distal area being patent, and these things would be coming from the CT scan. So what does this show you? Be ready before the anesthesiologist. IEP is contrary to general surgery. In surgery, the anesthesia will be induced, surgeon will come lazily, oh, now everything is done, now I will start my job. But in this case, it's reverse. You see on the back, before the induction has started, the operator is ready with the rigid bronchoscope. This is most important in central area obstruction because they will put the mask, give some fentanyl and propofol, and you may have precipitous fall in saturation. Now that you know the oxygenation window we had in discussion is 2 to 3 minutes. And now you are wasting 2 to 3 minutes readying your assembly and then going in. These are practical things. So you have to be ready before the anesthesiologist, before doing the central area obstruction case. For rigid bronchoscopic intubation, axis is most important. Always go in the central axis. If you are not able to get a good view, do not push the scope further. And also, once you are holding the scope vertically, you try that it does not grate over the posterior pharyngeal wall. So now I'll give a few slides, some points about each individual case, not in too much of detail. Foreign body removal is a bread and butter, case for interventional pulmonologists, but you need to keep some things in mind. If you are dealing with a very large foreign body, even though in adult you can remove it with a flexible bronchoscope, it's better to use a rigid bronchoscope. And if the patient is in respiratory failure, it's always better to go with a rigid bronchoscopy. And some unusual complications you have to anticipate. Sometimes if the foreign body is long-standing, you see bronchograms distal to the foreign body. Those bronchograms may not be fluid. They may be infected purulent material. And it's not uncommon that you just pull out a simple foreign body out is no problem. But the whole infected material now spills into the contralateral bronchus and you have post-procedure sepsis. So you need to have your suction ready, bronchoscope ready, anticipate what can go wrong. All I'm saying again and again is, don't get focused on the problem per se, but what can be, a consequence of handling that problem. Central area obstruction, one very important message I'd like to give. You will have lesions like this. You will have a very significant airway stenosis or a tumor. Do the diagnostic bronchoscopy very carefully in this situation. Even if you want to choose the thinnest possible scope. Because the more you go and more you come out, bleeding and edema can happen. Your job is to just have a quick assessment and come out to plan for the procedure. It's not like spending a detailed anatomical assessment and teaching so that the bleeding and edema can happen. So quick assessment bronchoscopy. For benign tracheal stenosis, you will have multimodality things going on. You might be giving cautery cuts, you may be giving rigid dilatation or a balloon dilatation. Each of them has specific precautions. For the sake of time, very difficult to sum everything up in this time. If you are doing a mechanical rigid dilatation, always be sure of the axis. If you are a beginner person who is trying to dilate a stenosis, if you are not comfortable with rigid dilatation, no problem. Take the rigid, don't use a rigid dilatation, use a balloon dilatation. So I think balloon dilatation is safer for somebody who's not used to rigid dilatation. And if you are doing rigid dilatation, always have the central lumen in view, because the one important complication is going into a false tract or a false axis, and once that happens and the stenosis is tight, you can really lose the air. So I think in that case, safer is to use a balloon. If you are doing electrocautery assisted dilatation like this, electrocautery knife has a lot of power. It can just cut through the airway and go distally. So once you are doing that, you take care that you use the minimum force and have a control and have a power settings which are little low. These would help you in having a cautery knife perforate through the airway. Airway tumor debulking, an important scenario. So if you are doing debulking and coring, just note these, 2 points in the end which are very important. If you use hot therapies, a debulking of a tumor with hot therapy will make the procedure safer. So if you do, electrocautery debulking, it will reduce the requirement of coring. And once you are doing coring, take care of axis. And one very important thing before coring is distal luminal patency. if you don't have a clear assessment of distal area patency, or the distance of the lesion is quite close to the division or a carina, be careful with coring. So it's say I'll be happy with an upper tracheal or a mid tracheal tumor to core rather than a lower tracheal tumor, because as soon as you core, the rigid bevel will hit the carina. So I think these things depend on, and these you will understand by CT scan. So do the CT scan assessment very well. Electrosurgery, we had the issue. Once you deal with these large flopping tumors, especially in the bronchus, once you cut them off, they can fall to the other side. So a tracheal flopping tumor is less dangerous than a bronchial tumor. Reason being, a bronchial tumor has occluded the entire bronchus. That lung is not ventilated. That tumor, if it falls into the normal size, will have more complication. If it is in the trachea, both lungs are ventilated, that's not. So I think it seems that tracheal is more complicated, but a unilateral bronchial obstruction is more complicated. Cryorecanalization, Dr. Rajiv mentioned, once you pull out tumors using a cryoprobe sticking, they can profusely bleed. So I think avoid cryorecanalization for flexible tumors. You should reserve it for tumors which are, relatively less vascular. And especially if you are dealing with these vascular tumors like carcinoids, I think you need to be careful. This is a very old case in which, we attempted coring because of lesion, but I think better would be to deal with these lesions with electrocortical smearing before you attempt coring. Hemoptysis, we've had an important talk. So for hemoptysis, one thing I would like to say is that rigid bronchoscope is very useful. If you are only a diagnostic bronchoscopist, still a rigid bronchoscopy intubation skills would come to your rescue handy. Because if there is a lot of bleeding during diagnostic bronchoscopy, I think sometimes it's nothing short of a rigid bronchoscopy which helps you to go in and clear out those clots and do a safe and effective lung isolation. Bronchial blockers, once you are placing large bronchial blockers like Dr. Ravi's figures, you have to take care that do an adequate size blocker. Because an undersized blocker, you place it. But after the procedure, patient coughs, the lesion, it can go and block the other side, and one side bleeding or something can happen. I think these are things you need to. So always and always, it's like what can go wrong should be on your back of the mind. That will help. Airway stents, we've had a good discussion in the morning. One point I would like to make, only one point for stents is, if you have decided to place a stent for a tumor or an obstruction, don't be very aggressive with debulking the tumor. Your job is to go as safely and cover the tumor, and that will be done. Because these stents have a lot of radial force. They will push the tumor. So if you have, say, an obstruction like this, you know that both bronchi are not narrowed and I want to place a wide stent. A straightforward way will be to just put the wide stent without bleeding. Now, if you think I'll go and first open the bronchi, I will debulk the tumors, that is going to lead to problem. So you have to think what is the safest and the quickest way to finish off the procedure. And I think once you're placing stents for malignancy, don't attempt too much of debulking. Sometimes unusual things will happen during stenting. This is a large thyroid mass, which is actually compressing the trachea. And if we saw the CT, the extension of the mass is from the upper trachea entirely to the right main bronchus origin. So this is a long obstruction. So we went ahead and placed a wide stent because of the cranial obstruction, but then what you realize, the upper part is still not covered. So you need to keep another stent handy to cover the upper part. If you didn't study the CT previously, you just ordered for a wide stent, then you will realize I need another stent. So these things can be prevented by a quick, careful assessment before CT, and then that would lead to a smooth procedure. Last 3-4 slides on some unusual, complications before I sum it off. During silicone stent, this is one complication which can happen once we post. Any idea what is this? This is a folded stent. When would a stent get folded? If you put a large stent with respect to a small stenosis. In silicone stenting, I think you need to have a careful assessment. If you put blindly a stent which is larger, this will fold and this will cause apnea sometimes. It's a real life scenario. The stent can block the ventilation, and silicone stent cannot be manipulated by a small flexible forceps. You need large forceps. You will have only 1 or 2 large forceps max in your room. And if there is a forceps malfunction, this can happen. And then you can have a problem, you cannot take the stent out. So I think adequate sizing of a silicone stent is much more important than a metal stent, because in metal stent at least it will open by itself. Silicone stent won't. So take care of that. There can be complications. Dr. Girish will be talking about that. The balloons can burst during cryobiopsy, they can lead to bleeding. Complications can be delayed, they don't happen immediately. Patient goes home after cryobiopsy and develops a pneumothorax and a pneumodestion later after procedure. So follow up your patients on a phone call also. This is one very unusual complication which we had. This patient was planned for airway stenting and only via rigid bronchoscopic intubation and an airway contact of the stent, patient developed asystole and bradycardia. Nothing was done. So this is, some patients who may be unusually sensitive to a vagal stimulation, and then, luckily with stopping of anesthesia and atropine, it recovered. These are entirely unexpected complications. I mean, I don't know how you plan for them, but these things can happen. With stents, you can have pseudomembrane formations. So keep a watch, do surveillance bronchoscopies. And this was an interesting case. We placed the silicone stent, and the next morning patient came, I cannot speak. So what happened? The stent, instead of going down, came up through the vocal cords, and the vocal cords were not closed. So this is a transglottic, migration of a silicone stent. Why will it happen? If the stent is undersized, or if it was a lymphoma or something, and it just shrank after the therapy, and the stent can move up. And this we talked about last slide. That if you, this was one of our cases. Dr. Ritesh will remember. So this was a left main bronchus tumor, which after debulking fell to the right main bronchus fell to the left side, and there was hypoxemia. So this is a migrating tumor phenomenon. So take care of that once you are dealing with tumors. So this is my last slide. So patient safety. Once you are doing therapeutic bronchoscopy, more than the procedure, only one thing should be going on in your mind, and that is, can I ventilate the patient or not? You should have this discussion with your anesthesiologist multiple times during the procedure. The patient is getting ventilated or not. If the anesthesiologist tells you ventilation is not happening, before the saturation drop, you have to act. Because stoppage of ventilation means that things are wrong. You go and correct that problem now, then think after the procedure. If you will follow this principle, then I think a lot of serious complications would reduce, because you will act during the apnea window rather than once the apnea window has stopped. Airway bleeding, we've had a lot of discussion. Airway laceration and perforation can happen in post-TB strictures, so be careful with aggressive dilatation of post-TB strictures. They can tend to, have a problem. Elderly patients do a cardiovascular risk assessment. And I think if you learn the rigid bronchoscopy intubation technique well, these injury to teeth, lips, tongue, and pharynx structures would not be very common. And I would still say that serious complications are rare, provided one is careful, and the team anticipates the complications and acts accordingly. The problem will happen is that once you are too visual about the procedure, you are so lost in the procedure per se that you forget about the things which could go wrong. I think if you have those discussions, I think everyone will second this point, that if you have that discussion, complications will be reduced. Thank you.